adolescents, information regarding catatonia has been accumulated in the past decade. Our awareness has increased in this last decade as well, but the diagnosis is not new. It was in 1874 that Calvan diagnosed it for the first time. When described and diagnosed for the first time, those years, a general brain dysfunction was thought to be the cause, but rather later stages the connection with schizophrenia was highlighted, and until 1970s the connection was cherished. Its relationship with mood disorders was neglected. In recent periods, in children and adolescents, catatonia seems to be gaining prevalence. After the 1970s, there has been much emphasis on catatonia's relationship with mood disorders, and when DSM-5 was being redacted, catatonia actually appeared, or the discussion was that should it appear as a separate category or should it continue as accompanying other psychiatric disorders. And those authors who want catatonia to continue as a separate diagnosis category defended that if this were the case, awareness would increase, our treatment and clinical knowledge will also increase. The other group, saying that it should continue in addition to psychiatric disorders, said that if it became separated, it would be neglected. Now, the DSM-5 Psychosis Working Group worked on catatonia and thought that catatonia should not continue as a sub-diagnostic category of schizophrenia. So schizophrenia, depression and mania, a catatonic stage can be diagnosed according to the DSM-5. It preserved catatonia as a result of other medical conditions, and if there's catatonia and the underlying psychiatric disorder is not very clear, it should be called catatonia, not otherwise specified. Now, catatonia is now accepted as a motor and mood dysregulation syndrome. It can occur in men and women of all ages. In psychiatric clinics, it's observed in about 10% of the patients that are treated according to different studies. In children and adolescents, let's have a look at the catatonic symptoms and the difference. Now, in children we have mutism, stupor, and waxy flexibility. Clinical experience also shows that in some catatonic patients there is also incontinence. Now, when we look at this table, to go back, we know that catatonic findings symptoms are very clear. Mutism, posture, negativism, grimacing. These are very easy to spot situations. Nonetheless, diagnosis of catatonia is sometimes overlooked in children and adolescents. Now, why is this the case? Its historical connection and association with schizophrenia might be one reason. There is also a perception among clinicians that there is no treatment, and it might be a reason to overlook catatonia. Again, clinicians sometimes do not fulfill physical and neurological evaluation. The indecisiveness when it comes to the implementation of ECG in children, and catatonia being classified as a severe psychiatric disorder brings, of course, the concern of potential stigmatization against children. So these are some risk factors for overlooking the condition. So, in what circumstances do we see catatonia cases? Well, it's actually different in children than is the case in adults. In mood disorders, yes, catatonia is more prevalent, but in children we see it with different manifestations. We can have autistic disorder. In the past decade especially, catatonia can be seen with autistic disorder, and awareness has now been on the increase. Mental retardation, Prader-Willi syndrome, this integrative disorder in these, catatonia can also be seen. Medical situations are important in adolescents and children. Psychotic disorders, again, second most common reason of catatonia in adults and children. Substance abuse disorders, similar. Different than adults, we started to see catatonia with tic disorders and also drug-induced movement disorders. Catatonia is also seen. This, one of the widest studies in the field. It's actually the only study with catatonia in 66 cases. It's an 18-year study, started in 1995. Hospital-admitted catatonia cases were retrospectively screened. And here you see the psychiatric conditions distribution in children with catatonia. Different than adults in this study, schizophrenia has more catatonia cases, but mood disorder is separated into different headings. When you bring them together, the rate is actually close to schizophrenia under mood disorder. A catatonic case can occur. Again, in PDD, we have 26, and in medical situations, again, you see the rate according to the study. In psychiatric patients, catatonia is actually not rare. Adult studies have shown rates between 7.6% and 38%, so catatonia is said to be present. Due to the historical connection between schizophrenia and catatonia, in 1976, Abrams and Taylor conducted a study, and they reported 66% catatonia rate with schizophrenia patients. And after this study, more attention shifted towards catatonia in mood disorders. DSM-4, after this study, highlighted mood disorder catatonia coexistence. 25% or more of mania patients have catatonia. Again, in more than half of catatonia patients, you can have sleep disorders. Of bipolar disorder patients, 20 to 30% can develop a catatonic case at any point in their lives. The most seen catatonic symptoms in mood disorder is mutism, withdrawal, flexibility, stereotypic behaviors, and echopraxia. In schizophrenia patients, however, the symptoms are taking posture and stereotypic behaviors. Now, there are some factors which have an impact on catatonia risk. There is no study, in fact, about this particular point, but certain other studies allude to this point. As age goes up, catatonia becomes more prevalent in children, according to this study. As depression episode number also goes up, catatonia risk goes up. Again, as daily activity and cognitive functions are degraded more and more, then the risk of catatonia is actually further increased. This is a study from our own clinic. It was an imaging study. We had bipolar disorder patients, and we also had healthy controls. We asked for catatonic features as well. The first group is 21, risk group is 20, and healthy control is 20 cases. Ages and genders are matched between the groups. During the first episode, in the bipolar group, catatonic features were found to be at 9.5%. Between the first episode and the protected treatment, catatonia turned out to be 19%. Once the treatment was initiated, in the following episodes, catatonia was seen at 8.4%. About 60% in the risk group had depressive disorder. Catatonia was about 5% in this group. Now, the GABAergic system is involved in the etiology of catatonia, and mood regulators can also play a role. Our study also highlighted that somewhat. Now, in autism, catatonia is also seen at a high rate. Awareness about this point is on the increase. In two separate studies, 12% and 17% prevalence rates have been demonstrated. Negative life events, changes in routine, losses, interpersonal conflicts, and especially in high functional autism, the expectations on children in regards to their capacity can trigger catatonia. Between the ages of 10 and 19 it can start. It's a slow onset situation, but then the full criteria for catatonia sometimes can be met by children. Now, when it comes to autism, repetitive self-harming behavior is discussed in connection with catatonia. It can be a variant of catatonia according to some, and especially repetitive self-harming behavior can occur. It can be treated with benzodiazepine, lorazepam, and ECG. Negativism, posturing, staring, and mutism are common to self-harm, repetitive self-harming, and catatonia. This is a study about repetitive self-harming behavior. It's a case report. An 8-year-old child with serious self-injurious behavior was provided certain treatment types. No response was obtained. EGT was applied to the child, and according to this case report, the self-injurious behavior went back to normal. Now, we're at this new phase when it comes to catatonic phase in autism. Now, the discussion shifted more towards this being a subcategory of autism. So new catatonic symptoms have now been defined and described that can occur with autism. An increasing slowing down in movement and language, difficulty initiating and completing movements, increasing passivity, and a clear lack of motivation. If these are present in autistic children, then we can potentially talk about a catatonic case in children, and anti-catatonic treatment can be started. This is another study from our clinic. These are the preliminary data only. We had autism and bipolar disorder children, and we looked into catatonic features in these children. We have 33 children in this chart with bipolar and autistic disorder. In 2 cases in this group we found catatonic features, so it's about 6%. In autistic children, the rate is actually higher, so what we got is slightly lower, but the study is still ongoing. Before proceeding with treatment, we know that in a catatonia case, the symptoms of patients can be mutism, remaining in a certain posture, and refusing oral intake. In these children, there are complications related to these conditions: dehydration, muscle electrolyte imbalance, and ensuing complications, deep vein thrombosis, pulmonary embolism due to immobility for a long time, and of course it can be life-threatening. Therefore, an effective treatment in catatonia starts with a rapid and correct diagnosis. If psychomotor functions and general reaction levels are degraded in the patient, then you should start suspecting catatonia. Now, we have clear information as to the treatment of catatonia. Lorazepam and EGT are very effective. Side effects are actually low. 80% to 100% effectiveness have been reported with lorazepam treatment. In adults, lorazepam can be used up to 30 milligrams in dosage. In children and adolescents, we can use it up to 24 milligrams according to different studies. In case reports, we've also seen that lorazepam is kept at 3 to 6 milligrams, and therefore they might be obtaining lower effectiveness figures. So when up to 24 milligram lorazepam is used, high dosage, of course, the patient should be monitored for side effects. There are 3 three studies with higher number of cases in children and adolescents. 12 to 18 cases are available in each of these studies, and they receive 1 or 2 dosage of lorazepam, and they obtain very high response rates against catatonia. Usually in 24 to 48 hours, the response and efficiency is the effectiveness is almost 100%. In non-responders to lorazepam, if the patient has idiopathic fever, tachycardia, and severe blood pressure changes, you need to resort to ECT, and in the second option, ECT should be the first choice. Without any delay, ECT should be applied. Now, in children and adults, you place dual-phase electrodes to apply ECT, and more seizures might be required for recovery in children and adolescents. If you use lorazepam on the patient, and if during lorazepam catatonic symptoms worsen or if they not recover properly, then the recommendation is to switch to ECT, and ECT plus lorazepam can be used together. And if lorazepam prevents a seizure when doing ECT, then you can use benzodiazepine antagonists. This is the treatment part of the study I showed you. 66 patients were enrolled, and in 77% benzodiazepine was given, and treatment response was 65%. Acute onset, low symptom severity have been found to be correlated with better response to treatment. Posturing, mannerism, and these two have been associated with poor response. Adult studies have also shown that when there is symptoms and signs of mannerism, then it's related with poor response. Being a boy, a male child, is also found to be a bad indicator compared to girls. One of the important findings in this study is that independently from the underlying psychiatric disorder, the patients have responded to treatment. When we look at adult studies, usually schizophrenia patients with catatonia respond poorly. This is another study. It's a retrospective study, 1985 to 2009. Publications over PubMed were scanned. 59 child and adolescent cases were found with ECT treatment. In these patients, response to ECT was 76% and 5% was partial response, so the rates are quite high. In addition to lorazepam and ECT, in treatment, in parallel to the etiology of catatonia, other agents can also be used. One is dopamine agonists, and I'll skip this quickly. Glutamate antagonists, anticonvulsants. In the treatment of catatonia, the most debatable treatment medication group is antipsychotic. The first generation antipsychotics may lead to catatonia or worsen existing catatonia, but second generation antipsychotics, we don't have that much clear data about them. Second generation antipsychotics can be used on a case-by-case basis in the treatment of catatonia, and some cases have been reported to have responded. One reason is that atypical antipsychotics, especially those that detach speedily from D2 receptors and those that increase the secretion of dopamine in the prefrontal cortex, they can help with catatonia according to studies. Especially recommended ones are clozapine, quetiapine, and aripiprazole. Some researchers have focused on second generation atypical antipsychotics based on the data that they are useful in catatonia. They started saying that as you treat catatonia, you can also treat primary disease. This is a screening I did on PubMed, atypical antipsychotics used in catatonia treatment. They are used in addition to benzodiazepine and ECT. Death was reported in one patient with olanzapine, and with risperidone, catatonia case actually worsened. Now, all atypical antipsychotics also have the risk of developing MNS. Therefore, the role of atypical antipsychotics do not yet have a very definitive role in the treatment of catatonia. Thus, in these patients, in these cases, if the patient has catatonia features and are using atypical antipsychotics, these should be stopped. Based on case studies and case reports, our approach to these cases can actually change, because you can use lorazepam plus ECT primarily on your patient, and you can have an easier time actually proceeding with the treatment of the primary disease. In catatonia, when treatment is cut short, catatonia can flare up. Therefore, maintenance therapy is actually recommended. However, there is no clear indication as to how the maintenance therapy should be done. It will depend on the catatonia symptoms and the tolerability of your patient. Usually it's between a week and a month. In some case reports, durations as long as 6 months to a year have also been reported. This is actually a summary of the treatment I've already explained, so I skipped that. To summarize, catatonia is no longer a rare condition. Its prevalence is actually high as opposed to what is thought, especially in cases with schizophrenia, autistic children with mood disorders. Catatonia should be screened. The treatment is determined, and response to treatment is quite high. Thank you.